Okay. Good afternoon, everybody. This is Dr. Adnan Almarzouq. I'm adult endocrinology internal medicine consultant at Dr. Sulaiman Al Habib Hospital in Khobar, Saudi Arabia. Today, I will talk about the role of thyroid antibody in assisted reproductive technology and its outcome. In my presentation, we will see the effect of the thyroid hormone and the thyroid antibody on the assisted reproductive technique outcome, and we will review multiple clinical trials to see the outcome according to those clinical trials. So hormone thyroid, of course, all of you know, play a critical role in the female fertility and pregnancy maintenance. It is essential for menstrual regulation and ovulation, and it is important for embryo implantation and pregnancy maintenance. The thyroid antibody may represent a state of immune dysregulation rather than thyroid dysfunction alone. Example of thyroid antibody, the TPO antibody, thyroglobulin antibody, the thyroid receptor antibody, thyroid peroxidase antibody. Its prevalence about 5 to 20% of the reproductive age women, and it is associated with infertility, miscarriage, implantation failure, and recurrent pregnancy loss. So there is a lot of conflicting data across the study about this issue, and this is due to heterogeneity in the TSH threshold in different laboratory and different place. Different also assessed reproductive technique that we will review here, and different population with the population selection bias. So the assisted reproductive technology is a medical technique used to help people get pregnancy. The main technique we have, it's IVF, which is in vitro fertilization, ICSI, intracytoplasmic sperm injection, IUI, intrauterine insemination. The infertility affect about 15% of couples worldwide, and we have around 8 million baby born with IVF technique. So what's the impact of thyroid and the fertility? The thyroid hormone influence ovarian function and oocyte quality. They also affect the hypothalamic pituitary gonadal axis. Overt hypothyroid dysfunction is associated with infertility, of course. Multiple clinical trials review this issue, and some of the studies said there is increase in the miscarriage rate with the thyroid dysfunction. Some meta-analysis said it have decreased implantation, especially with the antibody-positive ladies, and most of the studies said there is no effect. Most discrepancies are explained by the heterogeneity in the TSH control, assay variability, and population selection. So, what is the effect of this antibody on IVF outcome? It's a mixed result according to multiple clinical trials. Some said we will have immune dysregulation affecting the process, or direct ovarian effect, that the TPO itself has a direct effect on the follicular fluid, and also subclinical hypothyroidism effect impair the endometrial readiness for the implantation of the fetus. When we come to review of the literature and to see what we have from multiple clinical trial done about the thyroid antibody and the outcome for the assisted reproductive technique. For example, this meta-analysis based on 30 different studies, clinical and experimental obstetric and gynecology 2025 done. So this is done to review and evaluate the association between the thyroid antibody and the assisted reproductive technique. And the key outcome, the clinical pregnancy rate, the miscarriage rate, the live birth rate, implantation, and fertilization rate. So they found that there is no significant association between the thyroid antibody and the clinical pregnancy rate, the miscarriage rate, live birth rate, and similar pregnancy outcome between the thyroid antibody positive and thyroid antibody negative women. In the overall analysis, when they combined all the pregnancy method, thyroid antibody did not significantly reduce the clinical pregnancy rate in the entire population of this different studies in this meta-analysis. However, when they look at the IVF group alone in the subgroup analysis, the IVF showed greater reduction in clinical pregnancy rate in this group only. And the intracytoplasmic sperm injection showed minimal impact from the thyroid autoimmunity. Possible reason that the intracytoplasmic sperm injection bypassed the fertilization barrier affected by the antibody. Another significant finding that the antibody the thyroid antibody negativity affect early reproductive process. So the implantation rate affected around 80% lower in the antibody positive women. And fertilization rate is 13% modest, but statistically significant reduction in the fertilization rate also. So this supports the hypothesis that the thyroid antibody primarily affect the fertilization and implantation rather than the post-implantation development. The thyroid antibody may reduce fertilization and implantation rate. However, it does not significantly reduce the live birth rate and assess reproductive technique. Proper thyroid monitor, of course, is very important. Another clinical trial in 2022 to review the thyroid autoimmunity in female infertility and assess reproductive technique. In this clinical trial, they found that there is a possible reduction in the ovarian reserve in those with antibody positive, conflicting data on the anti-millennial hormone, lower number of retrieved ovocyte in some studies. Follicular fluid antibody has an effect also in the outcome, potential impact on embryo quality, and evidence remain inconsistent. Thyroid antibody may affect ovarian microenvironment rather than the systemic ovarian reserve. When we look at the levothyroxine treatment, it may reduce miscarriage risk in some studies, does not consistently improve live birth or pregnancy rate. Benefit in euthyroid women remain uncertain. So, but we have a consensus that to treat if the TSH more than 4 and consider between 2.5 to 4 with positive antibody. What about steroid therapy? Most of you saw patients seeking fertility with positive antibody, and some of the obstetric and gynecology doctor, they give steroid therapy. So what is the evidence behind this and the rationale? So steroid suppress autoimmunity activity, of course, reduce the inflammatory cytokine, improve endometrial redness, and potentially enhance implantation. The benefit of steroid likely reflect treatment of the selected immune phenotype rather than thyroid antibody alone. So the evidence supporting steroid use, low dose prednisolone 5 milligram per day in thyroid antibody positive women undergo IVF show higher pregnancy rate, higher live birth rate. Another retrospective analysis showed that combination steroid with thyroxine may improve the IVF outcome in antibody positive lady. What about in the opposite side, the evidence against steroid use? This clinical trial look at the use of aspirin plus steroid. Is it important and affecting or no? So they found no improvement in the IVF outcome with prednisolone therapy in euthyroid women with thyroid autoimmunity. The reason, thyroid antibody may be only a marker, not a direct cause. IVF outcome may depend more on the TSH control, embryo quality, maternal age. So, as you can see, this is the opposite. So, there is a lot of conflicting data until now in different clinical studies. Some with, some against use of steroid or thyroxine, as you can see. Current clinical perspective. So the current consensus, routine steroid for all thyroid antibody positive are not universally recommended. Management approach include check TSH, if TSH more than 2.5 with positive antibody, consider thyroxine. If recurrent failure, consider immune evaluation. Steroid in selected cases only, which is if you have recurrent implantation failure, recurrent pregnancy loss, suspected immune dysfunction. Why this is important? Because over-treatment of euthyroid women may expose patients to unnecessary therapy without improving outcome and without evidence that this is beneficial, and may also expose the lady to a risk without any necessary. So, the take-home message now, thyroid antibody not necessarily mean infertility. A lot of ladies, they get pregnancy with the IVF or even normal pregnancy where they have positive antibody and everything went smooth and normally. Strong effect on the implantation and fertilization according to some clinical trial. I mean, the antibody have effect on the implantation and fertilization. No proven impact on the live birth rate. Treatment should be individualized, of course. Not everybody should receive thyroxine or everybody should receive steroid therapy. Treat when TSH more than 4, this is sure, everybody agree with this. Many guidelines recommend maintain TSH below 2.5. Dose adjustment may be required during assisted reproductive technique due to estrogen change. No treatment usually needed if TSH less than 2.5 without antibody. Evidence for steroid use remain controversial. With this, I will conclude. I really thank you for your time and for your listening. I hope my presentation is smooth and easy to digest. I try to look at different clinical trial and review the literature, and I brought for you some of those clinical data with the controversy, and I hope this is useful. Thank you very much. Thank you.